Yeah. So good afternoon once again, everyone. Today I'm going to be taking you through the embryology and anatomy of the male genitalia. And I hope you can see my screen once again. Okay, fine, I'll proceed. As you already know, Dr. Kimani is going to supervise my presentation today. So this presentation is going to be in two sections. Section 1 will talk about the embryology of the male genitalia, and section 2 will talk about the gross and radiological anatomy of the male genitalia. So on the embryology of the male reproductive system, first and foremost, I want to remind you of a process that takes place within embryogenesis. It is known as the gastrulation process. And in this process, what happens in the embryo is the formation of the three primordial germ cell layers, mainly the ectoderm, the mesoderm, and the endoderm. Of importance to us, particularly pertaining to the reproductive system, is the mesoderm. We know that the mesoderm is divided into segments. We have the intermediate mesoderm, the paraaxial mesoderm, and the lateral mesoderm. Of coelomic epithelium, and it divides into two main structures. These are mainly the gonadal ridge, which gives rise to the reproductive system, and the phlogetic cord, which gives rise to the urinary system. So you can see here, this whole portion is the intermediate mesoderm, and this particular portion is the urogenital ridge. It divides into the nephrogenic cord and the gonadal ridge. So the genotype of the embryo, be it 46XX or 46XY, is established at fertilization. And during weeks 1 to 6, the embryo remains in a sexually indifferent or undifferentiated stage. This means that genetically female embryos and genetically male embryos are phenotypically indistinguishable. And during week 7, the indifferent embryo begins phenotypic sexual differentiation. And by week 12, female or male characteristics of the external genitalia can be recognized. By week 20, phenotypic differentiation is complete. So phenotypic sexual differentiation is determined by the SRY gene, and this can result in individuals with a female phenotype, an intersex phenotype, or a male phenotype. This SRY gene is found in the Y chromosome, and it encodes for a protein known as the TDF. Now, we have the indifferent gonad, which develops in the testis, under the into the testis, under the influence of the SRY gene. And within it are Leydig cells, which produce testosterone, and Sertoli cells, which produce Mullerian inhibiting factor. So in the presence of TDF, testosterone, and Mullerian inhibiting factor, the indifferent embryo will be directed to the male phenotype. While in the absence of the three, directed to the female. So phenotypic finally, the primordia of the external genitalia. A small quiz to refresh our memory. The urogenital ridge divides into which structures? I briefly talked about it earlier.
Somebody to answer that?
The Sada.
underlying the mesodome of the urogenital ridge proliferate to form the gonadal ridge. Gonadal ridge genotype which might the primordial germ cells originate initially from the epiblast in week 2 of development, and then they migrate into the endoderm and mesoderm layers of the yolk sac. So as I mentioned earlier, the Y chromosome of germ cells and Sertoli cells, which secrete the mesoderm between the seminiferous cords give rise to Leydig cells, which secrete testosterone. The primordial germ cells, Sertoli cells, and the Leydig cells and connective tissue storm of the testis are all derived from the mesoderm. The seminiferous cords remain as solid cords until puberty, when they acquire lumen and are called seminiferous tubules. This is a pictorial representation of the development of the gonad. You can see this is an indifferent embryo. And in this image here, this is an indifferent embryo, but there are primordial germ cells that are migrating towards the yolk sac. And by week 7, the sex codes in green have incorporated the primordial germ cells in blue. By week 20, we can see there's a degeneration of the paramesonephric duct in light red, and the mesonephric duct tubules in dark red continue to prosper. And then we have the seminiferous cords in green, the tubula erecta in green, and the rete testis all shown here. And this is a light micrograph of fetal testis showing the seminiferous cords composed of primordial germ cells and Sertoli cells. So the primordial germ cells are indicated by the arrow. And then the Leydig cells here, they are found within the This is a summary of the process that I've been talking about. You can see in week 5, there is a development of the gonadal ridges from the intermediate mesoderm beginning at the week 5 and at initial. So the cells of the coelomic epithelium and the mesonephros multiply, forming genital gonadal ridges during the 5th week of development. These genital ridges appear as longitudinal ridges or the kidney. And 6 weeks, we have primordial germ cells that migrate towards the ridge. And these germ cells will become the future sex cells, be it sperm or oocytes of the developing embryo. So as the germ cells migrate into the genital ridges, the gonad grows in size. And by the 6th week of these duct systems will form the accessory reproductive organs. That is the genital duct system and adjacent to the developing gonad. So I'll talk about the genital duct system on the coming slides. So the mesonephric, also known as the Wolffian duct system, will form most of the male genital duct system. And this will be composing of efferent ductules, epididymis, ductus deferens, seminal vesicles, and ejaculatory ducts. The paramesonephric or mullerian ducts will form most of the female genital duct system, and they will form the uterine tubes, uterus, and the superior part of the vagina. In the male, the paramesonephric system eventually will regress, and the mesonephric duct system will remain. In the female, the mesonephric duct system regresses and the paramesonephric duct system will remain. So we can briefly touch upon relative descent of the testis. So the testis originally developed within the abdomen, but later undergo a relative upper abdominal region away from the pelvic, but probably include the gubernaculum, which is a band of fibrous tissue along posterior wall that extends from the caudal pole of the testis to the scrotum. The remnants of the gubernaculum in the adult male serve to anchor the testis within the scrotum. The peritoneum evaginates alongside the gubernaculum to form the processus vaginalis. Later in development, most of the processus vaginalis is obliterated except at its distal end, which remains as a peritoneal sac, and this will be known as the tunica vaginalis of the testis. Now, still on the relative descent of the testis, testis deep T12, and the descent into the scrotum begins at 2 months of intrauterine life. By 3rd month at the iliac fossa, by 4th to 6th month, it rests at the deep inguinal ring. By 7th month, is at superficial inguinal ring, and 9 months at the scrotum. A small quiz. So which cells produce testosterone?
That is for Diana. Which cells produce testosterone, Diana?
I think it's the Leydig cells.
Yeah, Diana, you're right. Okay, I can proceed to the development of the genital ducts. So the paramesonephric ducts develop as mesodermal invaginations of the lateral surface of the urogenital ridge. The cranial portions run parallel to the mesonephric ducts. The caudal portions fuse the midline from the utero. The Mullerian inhibiting factor. The cranial portions of the paramesonephric ducts and the uterovaginal primordium regress. Part of the urinary system because these ducts are critical in the formation of the definitive metanephric kidney. These ducts then proceed to additionally form epididymis, ductus deferens, seminal vesicle, and ejaculatory duct. So a few of these mesonephric tubules in the region of the testis form the efferent ductus of the testis. So this is a summary of how the genital ducts are developed. At week 5, you can see here the paired paramesonephric ducts in light red begin to form along the lateral surface of the urogenital ridge, which is here in green, and grow in close association to the mesonephric duct in dark red. At week 6, induce formation of the sinovaginal bulbs, and the mesonephric ducts in dark red continue to prosper. At week 9, the mesonephric ducts in dark red and the mesonephric tubules in dark red establish contact with the testis and develop into definitive adult structures. So during this time period, the paramesonephric ducts in light red here, they degenerate in the males. So we can proceed to the development of the primordia of external genitalia. A proliferation of the mesoderm around the cloaca membrane causes the overlying ectoderm to rise up so that 3 structures are visible externally. We have the phallus, the urogenital folds, and the labioscrotal swellings. So the phallus forms the penis or the glans penis, the corporal cavernosa penis, and the corpus spongiosum. And the urogenital folds form the ventral aspect of the penis. The penile raphe is also known as that. And the labioscrotal swellings form the scrotum. Of clinical importance is especially we have conditions such as hypospadia, which occurs when the urethral folds fail to fuse completely, resulting in the external urethral orifice opening into the ventral surface of the penis. It's generally associated with poorly developed penis that curves ventrally, as shown in this here, and this will be known as the COD. So you can see here the hypospadias. We also have epispadias, which occurs when the external urethral orifice opens onto the dorsal surface of the penis. It's generally associated with extrophy of the bladder. And you can see in this image, there's 2 urethral openings on the dorsal surface, and it's a case of epispadias. We also have bilateral undescended testis, also known as cryptorchidism, which occurs when both testes fail to descend into the scrotum. Descent of the testis is evident within 3 months after birth, and this condition results in sterility. Undescended testis may be found in the abdominal cavity in the inguinal canal. So in this picture, you can see on both sides these undescended testis. We can briefly touch upon Turner stages of development for the male. We have stage 1, which coincides with 10 years of age or less than 10 years. In this stage, we see that there's a height increase up to 5 to 6 centimeters per year. The testes are 2.5 centimeters in size, that is the long axis. The penis is 3 centimeters in length and shows no growth. Pubic hair is vellus hair only, not coarse or pigmented hair. At Turner stage 2, which coincides with 9 to 13 years, the height increases at 5 to 6 centimeters per year. The testes are 2.5 to 3.2 centimeters in size, that is the long axis. And the penis shows early signs of growth in length and width. Pubic hair is minimally coarse, pigmented hair, mainly at the base of the penis. At Turner stage 3, which coincides with 12 to 14 years, height increases at 7 to 8 centimeters per year. Testes are at 3.6 centimeters in size, that is the long axis. The penis shows growth in length up to 6 centimeters and width. And then we have coarse hair, coarse pubic hair, which is pigmented and spreads over the pubis. And at stage 4, which coincides with 12 to 15 years, we have height increases at 10 centimeters per year, and that is the peak rate. The testes are at 4 to 4.5 centimeters in size, long axis. The penis shows growth in length up to 10 centimeters and width. And then we have pubic hair, which is adult and does not spread to the junction of the medial thigh and perineum. Also, we have the development of axillary hair and acne vulgaris shows. As for Turner stage 5, which coincides with 14 to 18 years, height increases stop after 17 years of age. The testes are at 4.5 centimeters in size, that is the long axis, and the penis shows growth in length up to 15 centimeters and width. The mature penis size reaches up to 16.5. The pubic hair has adult distribution, that is upside down triangle, and spreads to the medial thigh and does not extend up to the linea alba. So a bit of a summary of the female and male reproductive system, but I'll focus on the male. The indifferent embryo, components of the indifferent embryo, particularly the gonads, in the adult male becomes the testis, seminiferous tubules, tubular recti, retetestis, Wick cells, and the Sertoli cells. The paramesonephric duct regresses and becomes the appendix testis, if it remains. The mesonephric duct becomes the epididymis, ductus deferens, seminal vesicle, ejaculatory duct, and the appendix epididymis. The mesonephric lobules become the efferent ductules and the paradidymis. The first becomes the glans penis, corpora cavernosa penis, and the corpus spongiosum. The urogenital folds become the ventral aspect of the penis. The labioscrotal swellings become the scrotum. The gubernaculum becomes the gubernaculum testis. The processus vaginalis becomes the tunica vaginalis. So if there's no comments, I can proceed to the gross and radiological anatomy of the male genitalia.
You can give them time to comment. Very good detail of the embryology of the male genitalia. Any comments or additions? All right, Doctor, I think we can go on.
Okay, so I'll proceed to the gross and radiological anatomy of the male genitalia, starting with the testis. At birth, the testis measures approximately 1.5 centimeters in length and 1 centimeters in width, and reaches about 4 ml volume at puberty. The adult testes are ovoid and measure approximately 3 centimeters, that is the anterior posterior, and 2.4 centimeters transverse and 3 to 5 centimeters in length, with a volume of 12.5 to 19 mLs. But we know that the testis decreases with age, the size of the testis. Now we have the mediastinum testis, and from the mediastinum testis, we have several radiating septa extending into the testis, forming 250 to 400 lobules. Each of these lobules contain 2 to 3 seminiferous tubules, and these seminiferous tubules carry the sperm via tubula recti into a dilated space within the mediastinum testis, which is known as the rete testis, which drains into the epididymis through 10 to 15 efferent ductules. These efferent ducts are found in the head of the epididymis, and it's known as the globus major, which unite to form a single duct, that is the globus minor, in the body and tail region, which continues as the ductus deferens. So the arterial supply of the testis is achieved by the testicular arteries arising from the aorta, just below the origin of the renal arteries. As for venous drainage, the testes are drained by a plexus of veins known as the pampiniform plexus, which continue as the testicular veins. The right testicular vein directly drains into the inferior vena cava, while the left drains into the left renal vein. As for lymphatic drainage of the testis, it's through the lymphatics running with the testicular arteries, draining into the para-aortic lymph nodes. As for innervation, the testis receive autonomic sympathetic innervation from the spermatic plexus, originating from the aortorenal ganglia. So there's a variant anatomy known as the testicular appendage, and it's a vestigial remnant of the Mullerian duct present on the upper pole of the testis. It's attached to the tunica vaginalis, and it's present about 90% of the time. And I mentioned undescended testicles, also known as cryptorchidism, which is a failure of one or both testes to descend into the scrotum. On radiographic appearance, ultrasound, the normal testes have a homogeneous, moderately echogenic pattern. A testis is surrounded by a thin echogenic fibrous band, which represents the visceral component of the tunica vaginalis and the tunica albuginea. In the absence of intrascrotal fluid, the tunica is usually visualized only at its hilum as an echogenic structure where it invaginates into the testis to form the mediastinum testis. So this is an appearance of the normal testis and epididymis on ultrasound. On Doppler, particularly this color Doppler, you can see this is the appearance of the right testis on color Doppler. And intratesticular arteries are low resistance vessels with a mean resistive index of 0.62. On MRI, T1 weighted MRI, the testis and the epididymis have homogeneously intermediate signal. And on T2 weighted, the testis has hyperintense signal with slightly lower signal in the epididymis. Tunica albuginea has hyperintense signal on both T1 and T2 weighted image. So we can proceed to the penis. The penis is the external midline urinary and reproductive structure of the male urogenital system. On gross anatomy, the gross anatomy of the penis can be divided into 5 sections. Mainly we have the skin, the root, the body, the corpus cavernosum, the corpus spongiosum. As for the skin, it's loosely connected to the tunica albuginea, distally folded to form the prepuce, also known as the foreskin, at the corona of the penis. The internal layer of the prepuce is continuous with the neck and continues over the glans to the external urethral orifice. The frenulum is a median fold of the skin at the urethral aspect of the glans, running between the orifice and the deep surface of the prepuce. As for the penis, it consists of 3 cylindrical structures of erectile tissue. We have the penile crura, which is paired. It attaches to the pubic arc. This joins towards the symphysial border and continues as the corpora cavernosa. And the bulb of the penis is a median structure found between the crura and is attached to the perineal membrane. It narrows to continue as the corpus spongiosum. And the urethra pierces its deep aspect to traverse the bulb as the bulba urethra and continues to the corpus spongiosum. The body consists of 3 erectile structures, which are continuations of the structures described above. We have the corpora cavernosa on the right and the left side, and the corpus spongiosum on the middle side. During an erection, these cylinders become engorged with blood, and the urethra courses through the corpus spongiosum and opens at the tip of the penis gland via the meatus. We have 2 suspensory ligaments which support the body of the penis, mainly the fundiform and the triangular ligaments. So on the corpus cavernosum of the penis, they are paired dorsal structures encased in the tunica albuginea but separated by a median fibrous septum. The urethral aspect has a wide groove where the corpus spongiosum lies. A dorsal groove houses the deep dorsal vein and ends distally at the proximal part of the glans penis. The corpus spongiosum lies ventrally in the groove of the corpus cavernosum. It contains the penile part of the urethra, continuation of the bulbar part of the urethra, being approximately at 15 centimeters in length. It's cylindrical in shape and expands distally to become the glans penis. The glans dorsally over the distal corpus cavernosum. The corona gland projects from the base of the glans, and this contains multiple preputial glands, as well as on the penile neck, which secretes sebaceous smegma. This is a cross-section diagram that shows the penis. Of importance to us is the corpus cavernosum on both sides, as I mentioned, right and the left, and the corpus spongiosum. And we have these structures that support the penis. As for the supply of the penis, the arterial supply is derived mainly from the branches of the internal pudendal arteries. So these are the perineal artery and the branches of the common penile artery, all are derived from the internal pudendal artery. So the perineal artery, together with the posterior scrotal and inferior rectal arteries, supplies the tissues between the anus and the penile bulb. As for the branches of the common penile artery, we have the artery of the bulb of penis, also known as the bulbourethral artery, here. It supplies the corpus spongiosum and the bulbourethral glands. We have the cavernosal artery, also known as the deep artery of the penis, divides within the trabecula of the corpus cavernosum to either end in capillary networks or branches into Helcine arteries, mostly seen in the posterior region of the corpus cavernosum. Now, erection is caused by rapid flow from the Helcine arteries into the corpus cavernosum, and this distension further contributes to the erection as the venous outflow is obstructed. Now, the dorsal artery of the penis supplies the corpus spongiosum. It also supplies the penile skin by some branches coursing through the dartos layer. It supplies the tunica albuginea of the corpus cavernosum via a circumflex branch that courses around the shaft of the penis. As for venous drainage, it's achieved by the deep dorsal vein, which is unpaired, and it drains the corpus cavernosum and the corpus spongiosum, which passes through the urogenital diaphragm to enter the pelvis. And also the superficial dorsal vein, which are unpaired, drain the prepuce and the penile skin. As for lymphatic drainage, the penile skin accompanies the external pudendal vessels. Of the lymphatic drainage of the penile skin, we have the drainage accompanying the external pudendal vessels to the superficial inguinal nodes. As for the glands, we have the drainage to the deep inguinal and external iliac nodes. Erectile tissue and penile urethra to the internal iliac lymph nodes. As for innervation of the penis, it's mostly by the pudendal nerve and the pelvic plexuses of S2 to S4. We can move on to the epididymis. The epididymis is situated adjacent to the testis within the scrotal sac. Its primary function is the collection, maturation, and transport of the sperm via the ductus deferens. On gross anatomy, it's elongated structure, posterolateral to the testis. It can be subdivided into 3 anatomic regions. We have the head, also known as the globus major, the body and tail, known as the globus minor. So the total length of the epididymis is usually 6 to 7 centimeters, but it's tightly coiled and will measure 6 meters if uncoiled. The head is the largest. Here is the head. This is the body of the epididymis, and this is the tail. The head is the largest and most prominent part and is found at the superior pole of the testis. The head of the epididymis measures approximately 5 to 12 millimeters in length and may have a small projection called the appendix of the epididymis. The tail of the epididymis is found at the inferior pole of the testis. Now, seminiferous tubules carry the sperm via tubula recti to the dilated space within the mediastinum testis, known as the rete testis. The rete testis drains into the epididymis through 10 to 15 efferent ductules. The efferent ducts in the head of the epididymis unite to form a single duct in the body and tail, which continue as the duct deferens. So on arterial supply of the epididymis, the differential artery, mainly a branch of the superior vesical artery or sometimes inferior vesical artery, supplies the epididymis, and also a branch of the testicular artery, which branches off from the aorta directly, and branches from the cremasteric artery supply the epididymis. We have some sources that say that the epididymis is supplied only by the branches of the testicular artery. We have a variant anatomy, and that is the epididymal appendix, and it's a testicular appendage found at the head of the epididymis. They represent a developmental remnant of the mesonephric Wolffian duct. This is a grayscale, high-resolution ultrasound which shows the epididymis, and here, this is the epididymal head, and this is the appendix of the epididymis. A little more on the radiographic features. On ultrasound, the normal epididymis is iso to hyperechoic to the testis with equal or less vascularity on color and spectral Doppler. The head of the epididymis is visualized superior and lateral to the testis, you can see here, while the body and the tail are smaller with variable locations. On MRI, the T1 weighted MRI, epididymis has a homogeneous intermediate signal. On T2 weighted MRI, epididymis has hyper-intense signal with slightly lower signal than testis. On this image, you can see the epididymis in arrows, and they appear slightly hypo-intense relative to adjacent testis. And this is a T1 weighted image. We can move on to the prostate. The prostate gland is part of the male reproductive system, and it's the largest male accessory gland. It typically weighs between 20 to 40 grams with an average size of 3 by 4 by 2 centimeters. It's comprised of 70% glandular tissue and 30% fibromuscular or stromal tissue. And it provides 30% of volume, the volume of seminal fluid. On gross anatomy, the prostate is an inverted pyramid that surrounds the proximal urethra, which traverses the prostate close to its anterior surface at the base and then more centrally. It has a superior base, inferior apex, and 3 surfaces, meaning the anterior, inferior lateral, and the posterior. The base of the prostate is in continuity with the bladder, and it ends inferiorly at the apex of the urogenital diaphragm. The anterior surface forms the posterior limit of the retropubic space. The prostate is connected to the pubic bone by the puboprostatic ligaments. Its inferolateral surface rests on the levator ani fascia, and its triangular and flat posterior surface is anterior to the rectum and has a vertical median groove, which is palpable via digital rectal exam. It's separated from the rectum by a rectovesical. As superior and posterior to the prostate gland, the ejaculatory ducts pierce the posterior surface of the prostate below the bladder and drain into the prostatic urethra. The prostate gland lacks a true capsule, and so the so-called prostatic capsule is a pseudocapsule. Anteriorly and apically, this pseudocapsule is deficient. Laterally, the fascia fuses with the levator fascia, and the prostatic venous plexus, also known as the Santorini plexus, lie between and pass through the pseudocapsule and fascia. We have neurovascular bundles which travel posterolaterally at 5 and 7 o'clock and give off branches into the prostate and the apex and base. Now, the prostate has zones. Now, we can briefly touch upon the zonal anatomy. The prostate is comprised of 3 distinct zones with different embryologic origins. These zones are mainly the peripheral zone, the central zone, and the transition zone. So we have the peripheral zone here, the central zone here, and the transition zone here. So the large cup-shaped peripheral zone encompasses the central and transition zones and accounts for approximately 70% of the total prostatic volume in an adult and in a young adult. The peripheral zone is deficient anteriorly, where it is replaced by the anterior fibromuscular stroma, and the peripheral zone surrounds the distal prostatic urethra at the apex of the prostate and extends posterolaterally to the base. Prostatic tumors occur within the peripheral zone. The central zone is small and wedge-shaped. It constitutes up to 25% of the prostate volume and contains the ejaculatory ducts. It's posterior to the prostatic urethra and forms the base of the prostate. The transition zone is the smallest, and it makes up the remaining 5% of the prostatic volume. It's predominantly anterolateral to the prostatic urethra, and we have benign prostatic hypertrophy that occurs within the transition zone, and up to 20% of prostatic cancers arise from this zone. So superiorly, the anterior fibromuscular stroma is continuous with the detrusor muscle. Inferiorly, it blends with the levator muscles and puboprostatic ligaments. With aging, the central zone atrophies, and transition zone becomes hypertrophic. The prostate is related to other organs anteriorly to the pubic symphysis, retropubic space of the resius, posteriorly to the rectovesical fascia and rectum, superiorly to the seminal vesicles, superiorly to the bladder, inferiorly to the urogenital membrane and diaphragm, laterally to the prostatic venous plexus and levator ani. As for arterial supply, it's achieved by the prostatic branch of the inferior vesical artery, which is a branch of the anterior division of the internal iliac artery. And sometimes it's supplied by the middle rectal arteries. As for venous drainage, prostatic venous is achieved by prostatic venous plexus, which are in communication with the pudendal plexus to the deep dorsal vein and into the internal iliac vein, with some communication to the Batson vertebral venous plexus. We have to note that the potential route of spreading of cancer. As for lymphatic drainage, drainage is achieved mainly to the internal iliac, sacral, and obturator nodes, and some drainage occurs via the external iliac, presacral, and para-aortic nodes. As for innervation, parasympathetic S2 to S4 and sympathetic L1, L2 pelvic nerve plexuses. On radiographic feature, ultrasound is best assessed. It's best assessed with transrectal ultrasound. And you can distinguish some zonal anatomy, such as the central and peripheral zones. They appear low echogenicity, but usually more echogenic than the inner gland. And the prostate usually is 30 mL as an upper limit in volume. As for MRI, it's the preferred imaging modality. The prostate in T1 weighted appears as homogeneous intermediate signals intensity. And the anterior fibromuscular stroma is low in T1 weighted images and also low in T2 weighted image. The peripheral zone is high in T2 weighted image, similar to the or greater than the adjacent fat. And the central and transitional zones have lower T2 weighted signal than peripheral zone. And the capsule in T2 weighted appears as thin rim of low signal intensity. And you can visualize the distal urethra, which is a small ring of low intensity in the MRI. You can proceed to the seminal vesicles. The seminal vesicles are paired accessory sex glands of the male reproductive system. The seminal vesicles produce over 2/3 of ejaculate and is very high in fructose. On gross anatomy, the seminal vesicle is actually 10 to 15 centimeters long. It's a tubular structure, but it's coiled tightly, so it only measures 4 to 5 centimeters in length. These are the seminal vesicles. The excretory duct of the seminal vesicle unite with the duct deferens to form the ejaculatory duct here. So we can see the ductus deferens uniting with the seminal vesicles, and they form here at the ejaculatory duct. The seminal vesicle and it's related anteriorly to the base of the bladder, inferiorly and anteriorly to the prostate, posteriorly to the rectovesical fascia, medially to the ampulla of the ductus deferens, laterally to the prostatic venous plexus, and superiorly to the tip of the seminal to the peritoneum and the rectovesical pouch. On arterial supply of the seminal vesicle, the arteries that supply the seminal vesicles emerge from the middle and the inferior vesicle and the middle rectal vessels as well. On venous drainage, the vesicle venous plexus into the internal iliac veins. On lymphatic drainage, it drains to the internal iliac lymph nodes and is innervated by the sympathetic fibers from the testicular and hypogastric plexuses. On ultrasound, it appears as a fluid-filled structure which is located posteriorly and superiorly to the prostate gland. It's normally separated from the bladder by a fat plane, and it's less than 1.5 centimeters in diameter. Beyond that, dilated. There are conditions such as autosomal dominant polycystic kidney disease in which the seminal vesicles may appear larger than normal. On MRI, T1 weighted, it appears low to intermediate signal intensity. On T2 weighted, it appears as a convoluted area of high signal representing seminal fluid with low signal walls. You can proceed to the bulbourethral glands. On gross anatomy, the bulbourethral glands are located in the deep perineal pouch, posterolateral to the membranous portion of the male urethra and covered by external and urethral sphincter. This is the bulbourethral gland. Each gland secretes mucus during sexual arousal through individual ducts, 2.5 centimeters in length, which descend posterolateral and parallel to the membranous urethra through the perineal membrane and corpus spongiosum of the bulb of penis here to enter the floor of the bulbourethra. So the arterial supply of the bulbourethral glands is from the internal pudendal artery and the bulbourethral artery. Yeah. And innervation is through, it's innervated by sympathetic from the lower segments of the sympathetic chain via the hypogastric nerve. Lymph drainage is achieved from the glands to the internal iliac and external iliac lymph nodes. We can move to the ductus deferens. The ductus deferens, formerly known as the vas deferens, forms part of the male internal genitalia where it transports sperm from the epididymis to the ejaculatory duct. It is a paired 30 to 45 centimeters muscular small caliber tube that connects the epididymis to the ejaculatory duct. The artery of the ductus deferens is from superior vesical artery, which is a branch of the anterior division of the internal iliac artery. The veins from the vas deferens join the vesical venous plexus, which in turn drain into the internal iliac veins. For lymphatic drainage, it drains to the external and internal iliac nodes. As for innervation, it's achieved by the inferior hypogastric plexus. On radiographic feature, on plain radiograph, it's usually not seen unless there is a calcification, especially in patients with diabetes. On ultrasound, it appears as a tubular structure medial to the seminal vesicle. On CT, it appears as a tubular structure running posteriorly along the pelvic side wall. On MRI, T1 and T2 weighted, it appears as low signal tubular structure running from the deep inguinal ring to the ejaculatory duct. We can proceed to the ejaculatory ducts. The ejaculatory ducts are paired structures of the male reproductive system and they convey seminal fluid. So each ejaculatory duct is formed by the union of the excretory ducts of the seminal vesicle and the ampulla of the ductus deferens, and is approximately 2 centimeters long. The ducts course through the central zone of the prostate to open posteriorly on the verumontanum. This is the area. Just distal to the prostatic utricle into the lumen of the prostatic urethra. So I conclude my presentation here and I welcome any comments, any questions from you. Thank you.
Can we have additions to Dr.
Any comments? Additions?
Okay, that was a fairly detailed anatomy of the external male, the male genitalia, from embryology to anatomy. I was waiting for images to come. Do you have images or all those things? How do we evaluate them radiologically?
I have included some images, but
I
there were
saw
some.
I saw an ultrasound. I think what else did I see? An MR.
Hopefully, I'll include more, and then I will forward the slide to my classmates.
Is there something called is it called dactylography or vasculography?
Vasculography.
How do you evaluate the vast difference? Vasography. Is it called vasography?
I haven't heard of that. Maybe you can elaborate on that.
How do you evaluate the vast difference in imaging? Did you come across a vasogram?
No, I haven't.
You
Unfortunately, I haven't.
didn't. Okay.
Yeah, but I will read on it.
You can check on it, a vasogram.
Yeah.
The other things, of course, we would probably do MRI. And what about CT? Do we do CT? Can we evaluate that by CT?
Yes, of the ductus difference.
Are we able to see it on CT?
Yes, you visualize it as a tubular structure running
Yes.
across the pelvic side wall. I mentioned here.
Yeah, the common thing that patients complain of is infertility, male especially.
Yeah.
And they want to confirm that the vast difference is open, especially those patients who have got, is it called azoospermia? Or whatever it is, yeah, yes, aspermia.
Okay.
So you may want to see whether that vast difference is blocked. How would you do that? I think
By
Dr.
the vasogram you mentioned.
Yes. Does Dr. Chicha do them? Have you seen one Dr. Chicha doing? I think he does them. You need to include that anyway. But otherwise, that's a good presentation, anatomy. But we need to be able to identify all those structures you defined there at imaging. Yeah? That is the main thing that you are doing.
Okay.
Yes. Any questions? Now, maybe, Doctor, you can tell us, although you didn't mention, during obstetric imaging, ultrasound or whatever, are there milestones that we can rely on at imaging? Are there any milestones that we can say at this point you can see this, at this point you can see this, at this point you can see this? You can check that too.
I will check that too.
Yes,
But,
whether those milestones. When I know you mentioned them somewhere along the line. When does the testis reach the scrotum? You mentioned that, I think, at one point.
During embryology.
Mm.
Here, these are the milestones.
Okay, yeah. Can
The
we be able to
relative descent of the testis.
can we be able to design that on ultrasound?
Mm,
Did you come across something called cavenosogram?
no, I haven't. I haven't.
You
But
didn't
I will
come across
definitely read on it.
cavenosogram?
Cavanosogram.
Yes, maybe not common, not commonly being done, because now we have MR. But we have also Doppler, of the penile Doppler. Have you come across that?
Yeah, I heard of it.
You've heard of it?
Yes.
Yeah, those are some of the normal things that you need to tell us. Now, if we are doing that Doppler, what we expect to see, things like that. Although we are going to be learning as we move on. Yes. Otherwise, it's a good presentation, and I don't see any questions. I don't see any comments. We all need to look at that presentation again, a good one. And we also need to look at the imaging anatomy of the genitalia.
Imaging anatomy of the genitalia. Okay.
Yes.
Thank you for the addition, Dr.
Okay, thank you. So have a good afternoon.
Okay, thank you.